for this study. I just want to thank everybody for calling in for this webinar, and I also want to thank everybody for the questions that you have asked over the past couple of weeks about this study. So Eileen, maybe you can help me advance the slide.
I gave you control.
Okay. So how do I advance the slide? Okay. So I would like to start by just talking big picture about the purpose of this study. And I think that this can address some of the very common questions that we're getting from you all. And so the purpose of this study is that for patients who have received curative intent treatment for their prostate cancer, and whether that's surgery or radiation, we want to determine if more frequent PSA testing leads to better survival for these patients, or whether frequent PSA actually leads to more harm for these patients. So the key of this project is we need to figure out how frequently every patient is getting their PSAs checked after treatment. And the frequency of the PSA is the key to this issue. So in order to answer the question, it's important to capture every PSA test the patient has had so that we can understand the frequency of patients having a PSA test and to know also based on the PSA if a patient has had a recurrence. Really, I think the ability to capture every PSA test is the key to the study, and I think this really hits many of the questions that we're getting from you all. If we don't think that you can capture, or you don't have the records to capture every PSA test, then that patient is probably not suitable for inclusion. Next slide, please. Actually, I'll go to the next slide. So many of the questions that we have received in the past couple of weeks relate to this overall theme of, is the patient eligible? So some of the example questions, what if I can only get some records for the patient but not all the records? Or what if the PCP's office responds but the urologist's office will not respond? I think all of these questions, I think what we need to ask really is, do you feel that you're able to get all the PSAs the patient has had after treatment? And if the answer is no, you're not able to capture all the PSAs because the urologist won't respond or you can't get all the records, then that patient is not suitable for the study. We really need every PSA captured so we understand the frequency that patient is being monitored after treatment. So now, in order to capture all the PSA tests a patient has had, now the original way we designed the studies, we were going to ask the registrar to get records from all the physicians of the patient and all the hospitals for every patient. In designing the study, we realized that that really was just a lot of enormous amount of work for the registrars, and so we simplified the study to really just get records from 3 places: from the primary care, from the urologist, and if the patient had radiation, then also from the radiation oncologist. So you don't have to chase down records from the cardiologist, the pulmonologist, or other people. We simplified it to just these 3 offices. And we have also created a screening questions to help determine eligibility, and that's based on the records from these 3 offices. So we thank you for the work that you're doing for this special study, but we have really simplified this quite a bit in the design of this and not asking you to get records from every physician in every hospital. So I want to discuss the 3 screening eligibility questions. Again, there's been a lot of questions from you all about eligibility, and I want to discuss this in the webinar to see if we can minimize some of the confusion on these issues. So the first screening question is, are medical records available for the patients for 5 years in the surveillance period, or until distant recurrence or death, whichever is first? Let me give you some examples related to this first eligibility question, just to hit some of the frequently asked issues. So what this first eligibility question is getting at is we need complete 5-year records from the PCP, the urologist, and radiation oncologist if the patient had radiation. So that's what the first question is trying to get at. Now, it is possible that you can have complete records, but the patient may not have seen every doctor every year. So it's okay, and the patient is eligible, as long as you're able to have complete records for the first 5 years during surveillance from these offices. And if a patient didn't see the radiation doctor, but you have complete records, but the patient just didn't see a radiation doctor for a year or two, that's okay. I think that the first question is getting at, do you have complete records from these 3 places? And if you have complete records, then the patient is eligible. And again, the patient may not have seen everybody every year. So a couple of examples here. If a patient dies in year 3 and you have complete records until the patient is death, now it's whichever is first. So if you have complete records until the patient's death, this patient is eligible because it's whichever is first. Second example, you have complete records from the PCP, but the urologist's office refuses to provide records after multiple tries. In this situation, you're not comfortable. You don't think you've captured all the PSAs the patient has had because the urologist's office will not provide records, and you don't know if the patient has had PSAs over there. Then the patient is not eligible because we don't have full information on the frequency of PSA surveillance for this patient. Third example, you have complete records from the PCP. The urologist's office says the patient never was followed there during surveillance. In that case, you have probably captured all the PSAs because urologist did not check the PSA and the PCP did, and you have all the records there. Then the patient is eligible. Again, the key question is, do you think you've captured all the PSAs from these 3 places? And if you think you have, then the patient is eligible for inclusion. And there is some confusion about the 5 versus 8 years. The screening question is that we need you to have at least 5 years available records for the patient to be eligible. So that's just eligibility. But once the patient is marked eligible, we ask you to please collect 8 years of data and stop. And so at least 5 years to be eligible, and then when you start entering data, you can stop after 8 years of data. So 8 years is not the eligibility. 8 years is when you can stop entering data onto the web form. So going back to the second eligibility criteria, for patients who receive primary surgery, surgery is their primary treatment, then you need records from 2 offices. You need the urologist office and you need the primary care's office. If a patient received primary radiation, and half of your patients will have been sampled to have received radiation, half your patients will have been sampled to receive surgery. If patients receive primary radiation, then we need the records from 3 offices, the radiation oncologist, the urologist, and the primary care for eligibility. The third screening question, if a patient has the patient has to have at least 1 PSA in the first 2 years during surveillance, and that you're confident that you've captured PSAs, all the PSAs, for 2 years after treatment completion. So these are the 3 screening questions, and if a patient meets these 3 criteria, then the patient is eligible. If a patient does not meet these 3 criteria, all of them, then the patient would not be eligible. There's been some questions about the PCP. It is possible that a patient may not have a primary care doctor. And so this question has come up. If the registrar, if you are 100% sure that the patient does not have a PCP at the time of treatment, and you have complete records from other doctors, then the patient can be eligible. But this should be a pretty rare situation. And I say that because when the patient was diagnosed back many years ago with prostate cancer, when the patient's first diagnosed with prostate cancer, somebody checked the PSA. And usually the somebody who checked the PSA is the primary care doctor. And so the vast majority of patients really should have had a primary care doctor at the time of prostate cancer diagnosis, because that person checked the PSA probably. It's very rare for a patient just to walk into a urologist's door and say, check my PSA. That's a pretty rare situation. But if you're absolutely sure that a patient does not have a PCP, then that patient could be eligible, but it should be a rare situation. And PCPs could be physicians, physician assistants, and also nurse practitioners. And I will turn over to Eileen. Thank you.
Okay. Let me just switch over. Okay. So we had some technical problems with the patient list this week, and all of the problems have been resolved. If you're still continuing to have issues, we recommend trying Google Chrome, since it's the best browser to view the web form. Patient replacement should occur automatically. So if a patient is initially marked eligible and later found ineligible as you are entering data, you need to email us at specialstudy@facs.org with the FIN special study ID and the reason for the change. But that should only be the case if you originally marked them yes ineligible and started working on other tabs. So, but if not, then you should just mark them ineligible on the eligibility section, and then they should be automatically replaced. If they are not showing up, then you should just refresh the page, and then the new patient would show up. Make sure to answer questions at the bottom of the PSA and scan tabs to avoid errors when submitting patients. If you think you've entered all the data for a patient and you're getting some errors when you're trying to submit them, then make sure that you've answered all of the questions on the web form. So only registrars and co-registrars will have access to the web form link on the Data Links homepage. If an error message appears during login, please try using lowercase instead of capitals for the password. If you are unable to log in to the web form using the same username and password as Data Links, please try using a different browser like Google Chrome or Firefox. Patient list is shown once you log in to the web form, and if you do not have any patients on your screen, you should email us for confirmation. But all the lists should be showing up right when you log in. So for PSA, PSAs need to be entered from all providers, and we always are stressing this, that PSA is very important for this study. PSAs do not need to be entered in chronological order. So for example, if all PSAs are collected from the urologist and the PCP office does not have any PSAs, that is still complete information and they're still eligible. Patients will have different frequencies of PSA testing. Some may be monthly, some may be yearly. Some patients may be lost to follow-up for a few years, have no PSAs for a while, and then show up to see the physicians again. So as long as you have the complete set of records, they are still eligible. They don't have to have a PSA every year. And Ron was discussing these scenarios as well. For recurrence, recurrence is coded based on what is in the medical records. It can be elevated PSA or the doctor indicating recurrence has occurred. And so if anyone has questions about that, it can be either one of those possibilities. The study communication, we are going to post all the emails that we send out and any information on our special study website, and it's listed here, and then also on the Cancer Forum and Standards Resource Library. We would like you to send all study-related questions to specialstudy@facs.org. Study-related questions sent to personal FACS accounts will be forwarded to the special study address, and a ticket will be created. either send an email through the contact form of the website or email specialstudy@fax.org email address. Please do not send both, as all the emails go to the same account. Please include all SINs in communication so we can better assist you and have the most specific information to help answer your questions. So emails for the special study are being sent from specialstudy@fax.org email address through an outside server. We sent an email about this earlier this week, but we just want to stress that you should be receiving the emails. If you have not been receiving these emails, send the following information to your IT department and ask them to put us on the whitelist. This is going to be probably used for others' communication in the future as well. Reminders that the special study is through the COC and the NCDB and is similar to collecting follow-up data for all NCDB patients. We are trying to collect 15,000 patients nationally. The deadline has been extended to July 24th, 2017 due to the initial technical issues. The letter template to the outside facilities is on the website and it's listed under instructions and resources. So the webinars, the NCRA CE certificate templates and previous webinars are posted on the special study website. These webinars cannot count towards Category A credit. All webinars will be weekly on Tuesdays at 11 a.m. Central Time for the entirety of the study. You should register each week using the same link. The link will be the same every week, but you will still have to register each week. There are some individual email confirmations that are sent out, but they are not needed to participate in the webinars. So now we're going to review some frequently asked questions from the previous webinars. What should I do if a physician's office does not respond to requests? If the record request form was faxed, we would like you to call the office directly to request the record and make sure to send a letter template for the patient information from the COC so the office is aware that this data is required for COC accreditation. So if you are remote from the facility and traveling to outside institutions may not be feasible, we would like you to either fax or get the scanned record, or you can call somebody at the other institution in order to get the necessary information. We are only asking that you enter all the data on the web form. It doesn't matter which form you get it. People have different preferences, so we're not requiring you to have the paper chart. We just need you to enter the data into the web form. Does the patient have to die from prostate cancer? No, the patient does not have to die from prostate cancer. And as Ron said before, deceased patients can be eligible if they meet the other eligibility criteria. So if the urologist and PCP are retired, this has been a question about the surveillance tab. So we would like you to see if it's possible to collect the records from their office. Often physicians have retired, but the records are still available. All the NPIs are required for each provider. If the NPI on the surveillance tab is unknown, we would like you to use the format that we've used for all of the other data collection items. So we would use 8 zeros if there's no provider, then 8 nines if they have one provider but the NPI is completely unknown, or 8 sevens if it's unknown whether they have this provider. So it should be exactly how it's written on this slide. So there's been some questions on the NCDB data. So comparing what information the NCDB tab has for a patient when you log into the system, comparing to what the medical record contains, there's always more information available in the medical record. So than what was initially abstracted. So for example, Gleason's on prostatectomy weren't collected until 2010, and you might have an updated date of last contact that is not populating when you look at the NCDB section. So we're asking you to select no and fill in the most updated information. We would like to get the most current data for this study. And so if you are using the older versions while entering data for back in 2005 or whenever the patient was diagnosed, they're using the same board's manual as what was at the time, but we're asking for the most updated information using the 2016 board's version. Do we want all scans even if they are not related to prostate cancer? If the scan is definitely not related to prostate cancer, the scans are not needed. We've had some questions that some patients have multiple numbers of scans from other disease sites, and it would take a very long time to enter all the scans. So if they're not related to prostate cancer, they are not needed. If you would like to enter them, we will still accept them. So should skin biopsies be added and named malignant if positive? Non-melanoma skin cancer should not be included as new primary cancers or entered as biopsies. And that is also in the instruction. All right, so now will be time to answer any other questions. I will go back to our communication slide. If anyone needs to copy down the website or email address, I'll start answering the questions that have been answered for the remainder of the webinar. So I can go back to the top to show the information for the NCRA credit. It's right here, webinar number 3, NCRA 2017-034, and that will also be listed on our website when we post the webinars from now on. We had received some suggestions from registrars to do that, and so we will be posting that on the website.
Hi, this is Ron Chang. If I can just chime in, I'm answering questions as fast as I can, but I want to also thank you all for, based on the questions, it certainly seems very clear that many of you have begun the process of getting data for these patients and actually pretty far into the process. So I want to thank you all for doing this, and thank you for raising the questions, and we want to be very responsive to you, and hopefully we can usually get the questions answered very quickly from the time you ask them.
This is Amanda Franciscati. I just want to comment. Somebody asked us to discuss the issues with listing of patients, and I know Eileen had mentioned it briefly, but I just wanted to let you know that last week on, I believe, Monday or Tuesday, we had problems with the patient list where registrars were going in and the list had changed overnight, and this was, I think, the first or second day of the study. And we were made aware of that problem right away, and we got an announcement out as soon as possible. And we are very sorry for the inconvenience that this caused. I realize that a lot of you had to do double work. So if you're still seeing issues with your patient list, please send us an email with your FIN. We have been reverting patient lists back if the registrar had written down the accession numbers from the previous list and you'd already started working on them, we can revert it back, and we've done that for some people. But again, we're really sorry. I know you all have been working so hard, and I realize that that just set people back. So please do send us an email if you have remaining issues. And there were some other questions about technical capabilities for the web form in terms of printing the list and seeing and sorting the patients. At this time, we do not have that availability, but this is really good feedback, and we can definitely use it going forward for other special studies or other uses of the web form, and we can see if we can implement some of these in the going forward. So thank you.
If we need to print the patient list, we would suggest to use screenshots. And then also to add to what Amanda just said about the patient list is we would prefer if you send the special study ID, and if you do not have that, then please send the accession number, your FIN, and the sequence number. So we would prefer special study ID, but if you don't have that, then we would need all three of the accession number, sequence number, and FIN to replace the patient. Right now, we can assume that all the webinars will be 1 CE credit. So, and we will let you know when they drop down to 0.5 credits. But since especially at the beginning of the study, we're taking up the entire 60 minutes, so they will be 1 credit. So if you have a provider, but the provider is now retired or died, then we would hope that you would still be able to get the records from the physician's office or their prior workplace. If it's not possible, then the patient is not eligible. The letter to the outside physician can be found on the website. It's under instructions and documents. There's 3 separate letters you can use. One of them just has all the data items, and then one of them is the letter that the COC has sent out. You can still get credit for the webinars if you view them after the time. We're using the honor system, so as long as you view the webinar, then you can get the credit. If you receive less than 12 patients, then you will not receive any replacement patients. So those should be the ones that you would submit, and there would not be any other cases to complete for your site. So for Gleason scores for the year, so you would use the Gleason score for the year the case was diagnosed, and so that would be populated in the NCDB, and we are asking you to change it to the new Gleason score. So we would like it to be updated using the current 2016 Ford's manual. So for example, if Gleason score 7 was grade 3 in 2008, but grade 2 in 2016, please update it to grade 2. So if there is a rise in PSA over several tests, and then the fourth time it goes up, they begin hormonal treatment, is this a recurrence? If so, do they use the date of the PSA started to raise or the date the patient was started on hormonal treatment? So yes, this is a recurrence, and you would use the time of starting hormone therapy as the date. So for the question, if no lymph nodes were removed, how many lymph nodes contain cancer in the surgical pathology report? The answer would be 0. You cannot leave any questions blank or it won't let you submit the form. So all lymph nodes are PN. If no nodes are removed, then PNX. PT refers to the prostate itself. So if a patient was diagnosed in May, started hormone therapy in June, and then had radiation in April of the following year, they could still be eligible because the radiation started within 1 year of diagnosis.
So this is Ron Chen here. There's a question about what scans to enter in the web form. I'll talk a little bit about what we're trying to do. And I think sometimes typing questions back and forth, I think, leads to some miscommunication. So we want to capture, sometimes prostate cancer patients get scans in addition to PSAs as follow-up. And sometimes when the PSA starts going up, the doctor will order some scans to look for recurrence, metastasis. And so we want to capture this type of scan information. Now, so we ask you to please enter scans, X-rays, CAT scans, MRIs. Now, sometimes a scan could be a lung CT or a head CT, and it could be because of suspicion of metastasis from prostate cancer. So we want to capture all of this information. What we were saying on the webinar today is if there are some scans that are definitely not related to prostate cancer, if it's not, if a patient had a car accident and broken arm, we don't really need that. But you know, a prostate cancer, whether it's a scan of the prostate or a scan otherwise in the body to look for metastasis, we want to capture all of those scans, whether it's prostate or somewhere else in the body. If it's related to trying to figure out the cancer, the recurrence, the metastasis, then please enter that. But if it's clearly not related, the patient had pneumonia and had a chest X-ray, patient had broken arm and had an arm X-ray, if it's absolutely not related, then it's okay not to enter.
So if the physician states the recurrence, then this should be the date of the recurrence. If the physician does not state the recurrence, but the patient has begun treatment, then the treatment start date should be used as the recurrence date. We are asking you to record all PSAs in the surveillance period, not just monthly, every single one that has been done in the surveillance period. If you do not have any eligible patients and you have confirmed with us that your site is exempt, then you do not need to attend the webinars. An expected interval for looking for follow-up PSAs. This can range from monthly or more often to once a year. There's a wide variation and it depends on the patient. It is certainly possible that some patients will have PSAs but no testosterone or pathology or scans, and that is okay. So if you're missing 1 year of a PSA test within the 8-year of surveillance, is it necessary to ask the urologist and PCP for that year's PSA test results? Yes, we would like you to reach out to the urologist or the PCP for the records, as that is part of the eligibility criteria. If a patient received hormone treatment before surgery, the pathology report will not have the Gleason due to the hormone. What should they use as the pathological Gleason score? You should just use missing data. Once you submit all your cases, there will not be a confirmation sent. So as long as your patients are shown in the submitted section, you'll be all set. So we have shared some preliminary results of the last special study through the COC source and via email. Please email the special study at fax.org if you'd like to see those results. Results for this prostate study will not be available for at least 1 to 2 years. For some physicians and hospitals, this testosterone testing is routine. For others, it's not. There is a variation in clinical practice. If a patient develops basal cell carcinoma on the face, is that considered a new primary? No, we are not including non-melanoma skin cancers as new primary cancers. At this point, there is no cutoff date for the NCDB to replace cases that may potentially be ineligible. If the patient's urologist is the one who did radiation, then you still need a radiation oncologist for the patient to be eligible?
So Eileen, if I can chime in here. So that question was answered a couple of times. I just wanted to make sure that whatever we're saying here is the final answer. So I did not realize this, but for some patients who get brachytherapy, which is seed implants, the vast majority of these cases are done with a urologist working with a radiation oncologist together, because you need a radiation oncologist to calculate the dose from the seeds and whatever. I did not realize that there's situations where the radiation oncologist is not present. I was not familiar with that, but if that is the case and there's no radiation oncologist present to handle the radiation, to calculate the radiation dose, and if that's the case, then I think it's okay to then, if there's no radiation oncologist, then you can't request records from radiation oncologist's office. But the vast majority of these cases, the brachytherapy, the seeds, really should have involved a urologist and a radiation oncologist, the vast majority.
TURP is not sufficient for primary or curative treatment. TURP does not count as treatment. The patient should have had an either radical prostatectomy or radiation therapy as primary treatment. And this should have been, you should not have received any patients on your list that did not have either a radical prostatectomy or radiation therapy. So all of your patients should have one of the two procedures or treatment.
So thank you all for asking questions on this webinar. There are a handful of questions. I just wanted to make sure everybody knows that we're not ignoring your questions, but there's a handful of questions where, as the webinar is going on, we're not exactly sure of the answer. So we're not skipping your question on purpose, but these are things that may require a little bit of discussion, but we promise to get back to you quickly.
And that can be said about the emails too. If you don't receive a response quickly, that means we're checking on it. But we should respond to let you know that we received it and we're working on it. And we will get back to you as soon as possible. It is possible that some patients have no testosterone checked, and that is okay. If you find most of your patients are receiving PSA from only one physician, that is possible, and that is fine. If you know the patient was non-compliant and you have 5 years of follow-up data that is complete, the patient would still be eligible. The slides are located on the special study website for you to print out at the bottom of the page, and we have copied the website here, and we've posted it all throughout the webinar. So data collection ends only when there is a distant recurrence or death, or the period of 8 years ends. So even if you still have local or regional recurrence, you still have to complete data entry until there's a distant recurrence or death, whichever comes first. So we're asking that you please get records from each physician. Once you get the complete record, you may realize that some patients may not follow with each physician, and that is okay.
Eileen, there's a few questions that are asking about whether the questions and answers posted, from these webinars are posted somewhere. I think you might have mentioned this before, but maybe you can talk about it for everybody else to hear that.
I will post a document with the frequently asked questions on the web form. I'll update the ones that's already on there. It might not be the exact same ones that are listed here, because if we get duplicate questions and they've been answered, I'll kind of just clean it up a bit. So it won't be the exact same questions from the webinar today, but it will be all the frequently asked questions. I'll put that on the web form. If the patient was never disease-free, example after surgery, then it is counted as a recurrence. The date of the recurrence can either be the date of the first PSA check or after treatment, which documented the persistent cancer.
But in follow-up to that, if you're seeing patients that have never been disease-free, please send an email to specialstudy@fics.org. This was an issue in the last study, and we would like to make sure we understand how many patients this affects, and we may need to make changes based on that. So thanks.
So if a patient is on your list of patients, please record the scans this patient had even at other facilities. So if there's a case where there's a biopsy of a lung was performed and confirmed new lung cancer primary during the surveillance period, should this biopsy be captured under the biopsy tab, or is it just for suspected prostate cancer recurrences? This is lung cancer, so it is not a prostate cancer recurrence. Please record this as the new primary cancer tab. So the questions on the cancer forum will be answered on the cancer forum. We may pull questions for the webinars if they are pertinent to the larger group. When completing the web form, should you go ahead and submit the patient individually or wait until you get all the patients completed? You can do whatever you prefer, but if you think the patient records may come in for those completed patients, you may want to wait until the end of the study to submit. And once you submit, you would have to ask us to release the patient back to you if you had to make any other adjustments. If the patient meets the 3 screening questions, they are eligible. If a patient never had a normal PSA and it went up and down for several years, do you call this a recurrence? Yes, we call it a recurrence. So our facilities, for facilities that do not have enough patients from 2005 to 2007, some 2008 patients may have been added. The study involves NCDB data, which has been entered by registrars. Registrars are familiar with the coding rules used in FORDS and the NCDB. We recognize that CTRs are expert in their field, and that is why we rely on the CTRs for data collection in this study. That said, your Cancer Committee Chair and CLP should be aware of this study, as we have included them on several announcements through several different mediums.
Eileen, the last question that's being posted requests if you redisplay the slide with the links on it.
Oh, yes.
This is Amanda. A question just came in about changing data within the abstracts for never disease-free and recurrence. we are not asking you to change any data that's in your abstract other than the NCDB clinical information tab, which are data elements that are, the data there is pulled directly from the NCDB record that we have here at the NCDB. That is the only tab for which you need to update that information. We're not, at this point, we are not asking you to change anything to do with Never Disease Free because we're still trying to determine if this is a larger issue. And thank you to the registrar who brought that to my attention.
So please do not adjust PSAs because of ADVART. Just enter the lab results. We only want you to record PSAs during the surveillance period defined in the instructions. Any cancer-related scans should be entered. If a scan is entirely not cancer-related, then do not enter it. We will be sending out some sort of amendment to update the instructions based on the information stated by the PI. I think we are 1 minute over time, so if you have any further questions, just send us an email to specialstudy@fax.org. And we will see you next week at the same time. Thanks for all the questions.